Hi, everyone. I am Claire Laney, the Executive Director of AISNE, and you're joining us for a webinar about the changes in COVID testing protocols for higher ed in Massachusetts and what this may or may not mean for your boarding program. I'm joined this morning by my colleagues, Liza Alexander, Managing Director of our Northern New England, and Betsy O'Brien, Manager of Program and Communications here at AISNE. Our panel experts, who I will hand this over to shortly, we're joined by our friends and colleagues at Fusion Cell, Mike Klingshirn, Director of Consulting Services, and Matt Morrissey, Chief Operating Officer at Fusion Cell. Good to be joined by you gentlemen today. So let's get started. So we are here. Why we pulled this together? Let's just talk background for just a minute here. The reason why we pulled this together, I know many of you have worked really tirelessly to think about what testing protocols and programs you are right for your school. And but we wanted to pull up because there was a change in the Massachusetts Higher Education COVID-19 Control Plan that was revised to include slightly more detailed excuse me. Let me start again. To include more detailed testing protocols for students residing on campus. So this was a plan that was originally written in the summer, and then they made a minor revision regarding at-risk populations. And in that regard, they have recommended that at-risk populations are tested every 2 to 7 days. Now, that is certainly more detailed than what was originally written, which originally written, it just said that higher ed institutions with residential programs should have robust testing plans. And so when that change happened, I reached out to our friends at Fusion Cell to talk about what impact this may or may not have on our schools in Massachusetts with boarding programs. And so I'll hand it over to Mike shortly, and we're just going to walk through in detail what this may or may not mean for your program, and what role does surveillance testing have as we continue to maintain our schools in a safe and open way, and how boarding schools can interpret these changes, and then really importantly, what does an integrated strategy look like, and really what's the difference between boarding schools versus residential colleges. And let's remember that this guidance, these protocols were written for residential higher ed, not for our boarding schools. And then we'll share some examples of existing and developing testing programs. So with that, I'll hand it over to Mike. Thank you so much.
Yeah, I'll grab the first couple slides, and then I'm gonna let Mike do most of the talking today because he is much smarter than I am in this area.
Okay. Over to you, Matt.
So I'd like to thank Claire and Eliza for bringing us together with you this morning. I know there's a lot of other things you'd rather be doing on a Friday morning, but hello to the familiar faces that are out there that we've been working with. So we are going to give a little bit of the Fusion Cell background because some of you may not know who we are or why would we even be qualified to talk about this. I'm going to try and keep it short because a lot of you have heard the story already. We're going to talk through the interpretation of those changes, specifically the integrated strategies. We're going to look at a boarding school versus a residential college. Mike's going to get into examples of some of those other programs that are starting to develop now as well. So real quick, Fusion Cell, prior to March, we had no experience with COVID or pandemic outbreaks or virus containment as primarily a staffing company, working with civilian companies in leveraging military talent. But as the pandemic hit, we soon found out that we had access to a very unique pool of veteran talent that was uniquely qualified to help in these sort of circumstances. Every base in the US military across all branches forever is required to have virus outbreak and pandemic operation plans. It's been like that forever. They're also they're run by emergency managers, and those emergency managers are also the ones who've been deployed overseas for things like SARS, H1N1, and Ebola. So as a staffing company that has networks of folks into that pool, we quickly pulled together teams of these board certified health epidemiologists, backgrounds in pharmaceutical sciences, biology, biostats, folks that have done this before in real life and in real time, we brought some of these teammates together. We started working with companies, companies that were putting together their COVID-19 task forces, and figuring out how can we safely make our offices and our other environments better equipped to deal with the COVID environment, as well as how do we instill confidence that our employees can come back to a safer environment. Very early on, I want to say back in May, we were introduced to a private AISNE school in New Hampshire. And this was before anything had been put out by any of the states in regards to guidance. And we built their plan for them. I'm happy to say that the plans that after it came out from DESE and others looked a lot like ours. We'd like to say that they stole it from us, but I think it's more that it was just some of that sound science that it was based upon. So that got us very busy throughout the rest of the summer and now into the fall, with a lot of schools that, some are on the call today that you guys will recognize. If you think about a boarding school or a independent school campus, it looks a lot in some ways like a military base, for which these plans have been made for decades. So there's really not much that can happen on that campus that hasn't been thrown at our team before. And we've been leveraging that experience to help schools think through things like, first of all, how do I get back to campus, which was a big focus of our summer. As we got to the end of the summer, we started spending a lot of time talking about athletics. And then we've been spending a lot more time into winter athletics, but also boarding and a lot of other things. So as things change, we continue to get pulled back into, what do you guys think about A, B, C, and D? And again, fortunately, we have some experience behind us. So that's what put us kind of in this unique situation. Had you asked me what COVID was in March, I would have said it's something happening in China. Mike, on the other hand, who I'll introduce now, can tell you a little bit more about his background and kind of working in this sort of a world.
Thanks, Matt. So I am an epidemiologist, Mike Klingshirn. I'm working now at Fusion Cells, the Director of Consulting Services. My background has been traditionally with the Air Force. They gave me a scholarship to become an epidemiologist, and then they employed me after. So for the last 10 and some change years, I have been with the United States Air Force active duty. I just transitioned over to the National Guard because I really like the mission. I like wearing the uniform and helping people out. But the focus when I first joined way back in the day was pandemic influenza and how do we stop it if it comes back this way. And so we developed our plans and procedures at one base, and the Air Force really liked what we put in place because we took the old plan and we just threw it away and we rewrote it from scratch. The Department of Defense liked a couple snippets out of it, so they made it mandatory for every base under the Department of Defense to have those little snippets. So we got told to do our own product again, both by the Air Force and above, which is fun because once you do it once, it's pretty standard across the board. And really, that's what we bring to the table here is, dealing with public health emergencies and dealing with hospital infection control, epidemiology, biostatistics, and bringing that all to the civilian sector where it hasn't been at the forefront for quite some years. And that's the skill set that we've brought. And as we brought it in, we've been with 12 schools now, as Matt mentioned, a regional airport, and a bunch of businesses. So it's good to bring that skill set to where it's needed, and I'm glad to be on the team helping out. All right, so the recommendations. There's a lot of noise out there, and it's hard to figure out who's telling you the right thing and where it's coming from. So if you think about direction you would get from a health department, it could be your local, your state, or even the CDC as the Department of Health and Human Services, telling you what you should and shouldn't be doing. Then you have outside organizations. You may have the Department of Labor saying what you can and can't do when it comes to COVID and HR issues. You have the World Health Organization who's saying this is what the rest of the world is doing. You have social media or news media, and somewhere in the middle of all that is the literature. And that's really the scientific backing and the why behind all the interventions. And so as you are thinking through this, always remember that if a recommendation is coming out and there's a citation, somebody has looked at that paper, and sometimes it's just validating that it's applicable and can translate and addresses what it needs to address. And it has been fun looking through some of those and asking people, is that really what you wanted to say? But that's really about the recommendations, and really it's really about getting to the right information as information is changing in real time. And so, speaking of real time changes, the higher ed control plan came out with one extra bullet in their checklist for reopening higher education institutions, and that's around detection and response for COVID-19. And they referenced the education testing group's integrated testing strategy. So really bringing testing into what's already happening as a mitigation strategy for higher education institutions. So the very first page, the executive summary, talks about what it is. And I really wanted to pull out some of those sub-bullets. So the report is not intended to set standards for all institutions. In fact, it's really just considerations for all institutions. The scope is limited to testing only. And so they are only focused on what testing brings to the mitigation plans that are already in place. And remember that this is for higher ed institutions. This is not for boarding schools, but there's some parallels. And so as you go to the next slide, Matt, what is the report? Well, I'll tell you what it does. It definitely provides an overview and some good information. There are considerations on COVID mitigation, and it gives you considerations for non-testing based strategies and how to augment with testing based strategies. And there's explanations and different models of testing, which is great. But it definitely does not implement mandatory testing. It doesn't prioritize testing as the #1 way of risk mitigation. And it doesn't create a one size fits all standard that every school should be following. All right, so non-test based interventions. And this is out of one of the reference documents. If you go through those sub tabs and those footers, trying to think of the name of the organization, the Massachusetts High Technology Council, the HTC. They have a report that identifies non-test based strategies that have been effective at mitigating COVID. And these are things that we have seen in our disease containment planning on the military side for viral and respiratory droplet transmission items. So making sure that HVAC is up to standards, that you can increase fresh air, that your filters are able to filter what's in the environment, that you can disinfect the environment so that your building is as clean and safe as possible before people get in there. The exclusion controls, really making sure that the people that are coming in have done a health assessment. They've attested that they are as healthy as possible. They don't have any signs and symptoms. And then as they're transiting through the building, they're keeping their distance. They're wearing their mask, and they're wearing their mask appropriately. And they're washing their hands or hand sanitizing frequently throughout the day. The HTC said the same thing in their report, just not as fancy of colors as our side. So with those non-test based interventions, we're going to get into a slide that draws them out and talks about the relative rate of transmission that is reduced by implementing each of those 6 different areas. And so rate of transmission is really, if Mike Klingshirn comes in and there are no interventions, what would happen? And so they have set the baseline at a rate of transmission of 2.5. So Mike Klingshirn comes in, and throughout the day would infect between 2 and 3 people on average. Some will infect more, some will infect less, but that's about the average. So with no other interventions, one person can get a couple people sick. And that's really why this is so hard to contain, is it can spread easily between people. But there's also a phase where I don't have signs and symptoms where I can spread it. So that's where all these different layers come in to help reduce that risk of transmission. So if you implement all 6 of those layers of non-test based interventions, you can get it down to a point of 0.5 as your rate of transmission. So it would take 2 concurrently sick Mike Klingshirns in the space to get 1 other person sick. And so you really want to see a rate of transmission below 1 because it helps break that curve and break the chain of infection. So each layer does come at a cost. That cost could be the number of students that can be in a space at a time. It could be limiting enrollment. It could be needing more space. But really, it's long-term interventions when you talk about cleaning and sanitation and HVAC upgrades that are going to increase your indoor air quality, and they're going to increase just the overall appearance of the building. And I don't think we'll ever go back to the old normal. We'll have a modified old normal, but it will still be a new normal. So with this, these are distinctly different and independent of each other. So the top graph is non-test-based interventions. The bottom graph is what would happen if you did testing only, and that's at the frequency that they recommended in that study. So you get to the same answer, but you do it in two different ways. And so if you can implement masks plus a 6-foot distance plus attesting to your health, screening, ventilation, cleaning, and then other interventions like controlling flow, staggering start times, cohorting students, maybe putting in no-touch hardware within restrooms, you can get to that 0.5 rate of transmission. This is really why we see schools being more successful than other places, because there's a lot of control. Now, if you do test-based as an only, you get to the same thing, but you have to continually do it. And when, like I just said, if you increase your filtration and the indoor air quality and the number of times you're cleaning and how you're cleaning, these are typically going to be long-term effects and not just going away as soon as you stop, as soon as COVID stops, whereas testing would go away as soon as you stop testing.
And it's
So
also not,
effective.
it's also not immediate, Mike, too, right? That was one of those other big points that.
Yeah, testing sometimes has that lag in data where it could take 12 to 24 hours to 2 or 3 days in some cases to get that test back. So even if somebody was positive on their test, they've still gone a day or two in most cases where they've been in the environment. And this is for surveillance testing. We'll talk about that in a minute. So you get to different rates of transmission and you reduce that risk significantly with both pieces. So the non-test-based strategies and test-based strategies, which is why we call it the integrated approach, because we're really putting in a whole bunch of layers. And we're going to talk about the differences between college versus boarding schools. And I think these are pretty good picture examples of the level of control that you have over people's lives. If you have the young adults that are getting their first taste of freedom, you'll see masks everywhere and sometimes ignoring the rules. And then in the boarding school setting, a lot more adherence, a lot more discipline. All right, so control and autonomy. In the boarding school setting, you have that concept of in loco parentis. So you are the parents while the parents are away. So there's more structure, there's more control that you have over these students' lives. And that is apparent based on how well schools are doing versus some of the colleges and institutions that are out there. A big difference, and this is where I see one of the biggest differences, is the class selection. So you may only have in your school 1 or 2, say Algebra 1 classes. You might have some mixing of students in those classes. But if I was in college, and I'm thinking back to my days back at Bowling Green or University of Toledo, we had probably 100 different algebra classes and so many different schedules that the chance of you overlapping with a lot of people throughout your academic career was pretty minimal. And then you have age and what people have access to. So if you have the ability to say lights out at 9 or 10 or whatever, no gatherings, and you can go to study hall and have sports. I mean, that's pretty good. If you tried to do that in a college, they would say, I'm an adult, stop talking to me. This is my life, let me live it. So there's some definite distinct differences between these two populations. And that is where we get into the next slide. So the 4 risks of transmission identified, and this is straight out of that report, the testing strategies for higher education. And that's from the testing group's document. So in the highest risk, you have residential students and individuals that have contact with residential students. As we talked about, the number of options and the differing times of day that you would have in a college campus could make it likely that you would have students that would not have as much interaction with residential students. In a boarding environment, you're going to have pretty solid classes, and I would argue that depending on the number of boarding students, most of your students and most of your staff would fit into the highest risk of transmission. And this risk of transmission is people that are going to be in dense spaces where, if you think about the boarding environment, you have access to only students. You have access to multiple students depending on the size and occupancy levels of the dorms. So you have the ability to have a potential spread that would be faster than if Mike Klingsher went back to his family of 4, and then we get quarantined, and then the 4 of us just sit in the house like we're doing exactly right now. I'm on quarantine.
Long story.
Yeah, long story, but it happens to the best of us, and asymptomatic people are crushing us. So your medium risk group, this is people that have limited contact with those boarding students. And then you can read it, the low and lowest. But I would argue that if you look at those those two categories, so boarding versus college, you could have a lot of students that are not in the highest risk in a college based on the number of class offerings and how they live their lives. But in a boarding environment, you're probably going to have most, or at least half of your students being in that highest risk. So as we talk about that, that drives increased testing to control transmission rates as one of those integrated strategies. Next slide. Yep. So as you're thinking through the process of how do we do this testing piece, just remember that if you're going to go with one of the surveillance testing methods, you're going to have a responsibility for the students. You're going to have a responsibility for the school. So students, they have to be able to do some of the stuff for collection. So you have to go on your scheduled day. That's going to be the #1 priority. Probably easier in a boarding school than in a university. They have to be able to swab the front of their nose, put it in a tube, give it to a person. But on the school side, you definitely need somebody, that competent medical authority that can order. So a physician, a medical director, nurse practitioner, somebody along those lines. You have to be able to distribute the kits, get them back. You have to be able to receive those results, and you have to have plans in place if there's a positive, but also a way to contact people, whatever the protocol is, if you're positive or negative. So thinking about the surveillance piece and how it fits into an environment and what those other pieces of that integrated plan look like. You may or may not have the support for this exact piece, depending on what your medical director looks like. So those integrated testing strategies, these are the way that those two plans merge, the non-test based with the test based, and then how does testing look depending on what you're doing. So we got a couple categories. Next slide. So onboarding in a residential program, whether it's boarding students or academics in the college world, you definitely want to have some sort of thumbs up, thumbs down as people are coming onto campus. It could be a baseline test for your day students, but the higher priority, because of the density of the buildings and the risk of uncontrolled transmission, depending on how much control you have within their lives, you want to be able to say thumbs up. These people came in, we had everybody test at a baseline, and prior to getting here, we had no COVID positives, and anybody who was positive stayed home until they met the return criteria. So that gives you a good thumbs up that the people coming in are as healthy as possible. So that's a risk reduction measure. Symptomatic testing, so that diagnostic piece, absolutely critical, especially if you have a high sensitivity for anything. So Mike Klingsher gets the sniffles, cool, go get a test. Diagnostic is 100% recommended, no matter where you are. Piece that kind of trips everybody up, especially in this sense, is going to be that surveillance piece. So how do you do that ongoing testing for asymptomatic and pre-symptomatic people? So people that don't have signs and they don't meet the onboarding criteria. So it's really just, what is a snapshot of our campus? So that falls back on that previous couple slides of, is it worth the money? I'm not saying it's not, I'm just saying that as you look at the other mitigations that have been put into place, going from a 2-person infecting one model to 4-person infecting one, it might not be worth the extra cost of testing. It's all going to be dependent on the school. But how does it fit in and what does it look like? So the CDC has their definitions. This is really going back to that central hub and the medical literature. So diagnostic, 100% across the board. There should be an option for this. So if you have signs and symptoms, if you've been around a lab confirmed case, if you've been referred to get testing by a health provider. So yes, absolutely have testing for those folks. If there's an outbreak in the local area, this could be an option for surveillance testing. If you are onboarding, that next bullet down, definitely a recommendation just to make sure that everybody in those high density areas are as safe as possible. But then there's going to be that surveillance piece. So what happens if the local health department are asking for expanding testing, and what if people volunteer for it? And that's really where we're talking about a little subset of that integrated testing strategy. And remember that health insurance will cover the diagnostic. Health insurance typically will not cover onboarding and ongoing surveillance testing, especially if there's no reason for that test. If you're asymptomatic, you're not showing signs and symptoms, and you don't have a defined exposure to someone, in some cases that would be, or at least in the insurance side, that would be considered a non-required test. So those are typically not covered. As you're talking about the testing strategies that are out there, PCR, most reliable. And then you have your assays, your antigen tests. These are typically fast. They can be done in 15 to 20 minutes with minimal lab oversight. It can be done at home in some cases. Lower cost, limited sensitivity depending on what test you're using. So it's kind of, it's good, but PCR is the best. And then as you talk about pooling test takes a bunch of samples and then runs it against one test. So you could have anywhere between 2 and probably 12 different samples into one pool. You run it against a PCR test. If it's negative, all 12 are negative. So you use one test to confirm negativity. But if it's positive, then you have to retest all 12 individually. So there is a follow-on test to make sure that you can identify the sick individuals. But I do want to make the distinction that in this case, from the Massachusetts HTC, that PCR pooling is the only pooling. So if you do a pooling test that uses the antigen test, so that immunoassay test, you can get wild variability in the number of people that are picked up. So they only recommend PCR pooling. And then antibody testing, that's really not for detection. That's more of just surveillance data. There's not a lot of diagnostic stuff you can do out of the antibody test. So pulling blood is more of just surveillance. And those come at a cost as well. So what have we seen? Just 3 examples of schools that we have seen as we've been working through the world of COVID testing at boarding institutions. The one was as students are coming back from their winter break, it's going to be an onboarding for everybody. So if you're a day student, you get a baseline. If you are a boarding student, you come with a test and then you get a test at day 7-ish. So you come, thumbs up, 7 days in, confirm, and if not, remove that person from the population, isolate and quarantine as needed, and then move on for there. But then no surveillance testing unless there's going to be an outbreak. And so that's really relying on those non-test-based strategies of that integrated testing policy. School will be onboarding for all students, diagnostic as needed. surveillance testing every other week. I think it's a 50% each week, so that every other week you have 100% of your student population tested. And then School C, same thing for the onboarding, every other week for the students, but they've also increased to add pool sampling of wastewater. So collecting wastewater from individual buildings to see if there's been any COVID in the wastewater. So it's a different way of doing a pooled sample. It's less invasive, a little more time intensive to get a sample, but it's definitely something that will give you a snapshot in time of what's happening on campus. So, you know, there's a lot of ways that you can go about testing. There's a lot of ways to fit surveillance into what an academic institution is doing. But I do want to say that that testing-based strategy, it's going to be dependent on what else you have in place. So final thoughts. The guidance is, as I love to say as an epidemiologist, it depends. You'll hear me say that probably 10 more times as we get into questions. So specific situations dictate the best testing strategy for schools. And that's going to be based on your local rates, anything that's required by your local or state Department of Public Health, and then anything that requires additional testing. So it could be your medical director saying, let's go to this, there was an outbreak. So it's all dependent. But testing is really just another layer in what you have already put in there. So we know what, we have defined numbers on what those different non-testing strategies can get us to. And so knowing that this is just an extra piece, it will bring that rate of transmission down. And so that's a good thing. So testing helps. There's the science and the optics. The science says that it is a way to reduce risk. The optics are, as I'm a parent, if I see testing, I think, oh man, they're going to identify something better. They're going to identify people that are sick, and my kid's going to, you know, never get COVID. And that's not always the case. Really, surveillance testing is out there, and it can help, but it's not a, you know, it just relies more on the test itself. I don't want to make it sound like the test is the end all. No one strategy is great, but it can help reduce some of those parent fears. So it's the science versus the optics. Current trends, it's probably a good time. There's 10 million cases. Johns Hopkins indicates that we are getting 1 million new cases every 7 days, 6 days. And so knowing that it's a 6-day to get to the next million in America right now, and we have not hit our coldest months, it's probably a time to consider or at least evaluate what testing strategies look like in addition to everything that's already in place. So testing does have limitations. We talked about this earlier, and it's the lag time, really, that's the biggest limitation. So if it takes 2 days to get back anyway, and somebody was positive, that's 2 days that they were in there exposing people. It doesn't indicate that you can stop a outbreak as quickly as possible. It just means that based on the frequency that you're testing, you may be able to exclude people before they start infecting other people. There's cost benefit to it, and it's going to be unique to the school and how often you do surveillance testing if you add it to your integrated strategy. But really, onboarding and diagnostic are going to be two critical pieces that you should be considering. And then last wrap up, if what you're doing is working, it will probably continue to work. We've seen a couple cases where there have been a few positives in some of the schools that we've looked at. And the nice thing is that in most of the cases, it was one positive person and nobody else within that classroom was listed as a close contact, and nobody else in that classroom tested positive for COVID. Now, they may have had to exclude themselves for a couple days for that 14-day quarantine period, but those mitigation, those non-testing based strategies do work. So keeping distance and wearing masks can reduce your rate of transmission significantly within your walls. And so if that has been working for you, make sure that you keep it up and you address complacency as it happens. So if I'm a faculty, a staff, or a student, re-emphasizing that you hold people accountable. So making sure that the mask is up, it covers the nose. If you're doing hand hygiene, that you're doing it often throughout the day. That accountability piece is critical.
And that's the last slide. I think, Claire will get into some of the questions, but I think one of the important things to remember, because I know we just threw a lot out about testing, the original, what kind of spurned this webinar was what higher ed came out with. And I think one of the key things the key takeaway is, first and foremost, that checklist that they came out with, back in June, they only changed that one box. That one box that we dove into here today, again, is not a mandate. It was recommendations. I know it was kind of scary to look at it. It almost looks as if they're telling you need to surveillance test every 2 to 7 days, right? But also to remember, and that's why we spent time on it, it was not geared for boarding schools. It's geared for higher ed, right? It's geared for college campuses. And there are some very significant differences between college campuses and what you might find in a boarding school environment. And Mike pointed all of those out. That being said, sometimes your constituents, your parents, don't care, right? So you as a school have to kind of get your hands around how important is it either to layer in, because yes, testing absolutely can help, but is there an optics piece as well that a school might have to tackle? And every school is going to answer that a little bit differently. So hopefully this gives some science and some practicality in your fingertips. And we're going to make the webinar as well as the slide deck available to everybody, so that you can have discussions and make decisions and feel a little bit more enabled to do so. I think that's what we're hoping to get through today.
Thank you, Matt. Thank you, Mike. And really appreciate just the balanced view that you're presenting here for everyone. Mike, you shared some sobering numbers with us about where cases are, but also the fact that if it's working in your community, whatever you're doing to layer your risk mitigation strategies, if that's working, it should continue to work. And this is just an opportunity to look at the role of testing generally, but surveillance testing more specifically. So I'd love to get into questions. And one Diane posed for you is about pool testing. And if there is a positive in a pool test, is then the retesting covered by insurance? And would that be then considered diagnostic?
Ooh, great question. I don't know the answer to that. And I think it's going to be dependent on the company that does the testing. Because if you have, say, 10 people in a pool, one comes back positive, and so they have to do 10 individual tests. They may just charge you for each of those 10 individual tests, and you might be able to recoup 1 or 2 or however many were positive from that person's insurance. But I don't know the answer to that. I think that's going to be on the contract side of how things are paid for versus can insurance cover it.
Diane, do you want to ask a follow-up question? We can unmute you.
I do. I was just wondering, so if we are doing pool testing and we come back with a positive, if we go back to our families and say, your child was part of a pool that has a positive test in it, you should reach out to your physician. Couldn't the physician then order a diagnostic test that the family can then do so they can determine if it's their child or not?
Yeah, absolutely. So that's one option. I would say that if you have done a pool test and you have a high suspicion that you have one or a few people in that pool, typically what happens with that test is, they take a sample out of each of the 10. They run that sample, and then when it comes back with a thumbs up, they typically run a reflex test on each of the 10 to tell you which one is positive. Because you already have the sample there and you already have a defined positive in there. It's typically way faster for them to do it and for you to make an appointment, go see a provider, come back. I would work it that way with the testing company. And if it means that, couple $100 saved you a couple cases in your school. Probably a good thing.
So we've been doing testing all along, every 2 weeks. And we've been doing individual PCR testing. So now we're looking towards the pool testing for the return back in January. And so the people we've been working with, there's 2 different ways that they can do it. One is they can do the pool testing with individual tubes of what you just explained, but then they can also do it without reporting and without individual, I don't know exactly what their lingo is, but
Yeah.
without their having to report to the Department of Health. It's really truly just a pool, and then they come back and say there's a positive.
Somebody
And
in the
then I
pool.
think it would come back to us as to what we wanted to do from there, because we would be the ones in administering the test here and pooling it here.
Okay.
So we would send them the pool test as opposed to sending the individual test that they then pool.
Okay. So the collection piece, the pooling piece, and the send out is all on you.
Right.
And then
it's
they
much
just
less
have the
expensive.
equipment and they just run it. Okay.
Right.
And it is much less expensive, but they have de-identified data on who's in that pool, so they would not have a requirement to report. The requirement to report would probably fall under the ordering physician of that follow-on test. So,
right.
Yeah, I mean that's definitely. So if the route that you go gives them de-identified data and they cannot run a reflex test, that's fine. And then yes, exclude all 10 people or however many are in that pool, and have them all go get tested under their insurance as being in a positive pool. And that way, their insurance probably should cover it.
Okay, thank you.
I would think that it would. Don't hold me accountable if it doesn't.
I'll come back to you. No, but thank you.
My name is Matt Morrissey.
Thank you.
Thanks, Diane. Other questions? We don't have a lot coming through the chat, but if you want to unmute and ask a question or raise your hand, I can then unmute you. I know a lot of people are thinking about, as we head into the winter months, as we head into breaks and coming back to campus after those breaks, what new testing strategies you might want to deploy. So now's the time to ask the experts. Yes.
Can I ask
Eric.
a question?
Yeah,
Hi,
sure.
Erica Rogers from Dublin School. One, from your perspective, as you see the landscape of testing and costs of testing and availability, as we kind of get our plans together for the second semester, we do surveillance testing now of about 30% of our population every week, and then kind of rotate through. And I guess there was a question, as we're looking at options, we're happy with who we're using, but kind of just cost analysis. Do you anticipate testing costs might go down? Or is there also a risk that as the demand grows, testing and availability becomes harder? So it's sort of like, do I lock in my plan now, or do I kind of cross my fingers and wait a little bit, but I don't want to get caught without, because what we're doing is working and I want to keep working?
That is such a tough question. So Erica, you're asking me to predict the stock market in the future, but it's fine. Let me give you my perception. So first, I'm going to start off with, if you're happy with it and if it's working, it would not be inappropriate to lock it in now. You're leveraging against any potential, spike in prices if, say, supplies become limited. And like we saw with PPE back in March when N95s were gone. A mask that was typically $1 now costs the US government about $15. I don't know if that was typical across the board for that amount of gouge, but the gouge is definitely there. And so I think you're leveraging really against that versus, is the cost going to go down and is it going to be a significant amount to play around with? I would say that is. So we did a webinar in October, and there were roughly 7 million cases in the US, and it took about 15 days to to get to that next million. And now we're at 10 million cases, and it's taking 7 days to get to that next million. So the time's about half. At some point, there will be a lot of cases and a lot of that's 100,000 tests every day that are being done, 144,000 according to Johns Hopkins, positive tests that are being done every single day throughout 50 states. So knowing that we are running through 150,000 tests every day, and that's just the positives, and there is a big chance that we could run into shortages in testing supplies. We've already seen shortages in reagents in the past. Whether or not the supplies are going to become limited, I would say that it's never bad to lock in, knowing that we've had shortages in the past. I know it's not a prediction of the future, and there's new tests that are coming out daily, and it might be a switch from PCR to immunoassays that you're doing, or those assay tests. But just making sure that it says that you will be able to test 30% of your students and not defined to a specific test, I think would be probably just as advantageous.
Thank you.
Thank you. We have a question in the chat from Teresa asking about return to campus and whether to staggered reopening or a one-time entrance is a advisable strategy. And I'm sure it depends, but maybe walk us through the pros and cons.
You said it. Yeah, it depends. So staggered reentry works in cases where people are coming in from higher risk areas, and that way you can stagger that entry of students coming into the boarding program by maybe a week or two to give them some time of quarantine and a few tests in the middle. That's always a good thing. But remember that as you come back to school, a staggered return allows you to work out things that are not going as great in real time, but without 100% of the students. And so as you're thinking through the process, if it's a boarding high school, if you did your high risk or boarders coming in from high risk areas first, and then staggered day students, you might be able to work out some of those kinks as they're happening, versus having 100% of the students on campus and you figure out something was bad to begin with, or there was a fault, or a weak link in the chain, and identifying that could be a route of exposure for a few students.
Thank you. Well, without any more questions, but I can give it another minute. We may just thank our friends and colleagues, Matt and Mike, for sharing their experience and expertise with us. Thank you all for sharing your time with us this morning. And the recording and the slide deck will be available on our website once we've rendered the video and done all that. And we will email you when that's ready. I hope you all have a wonderful weekend. Stay safe, stay strong, and stay in touch with the AISNE team. We're here to support you. So thank you so much, everyone. Take care. Bye.
Thanks, everyone.